السلام عليكم ورحمة الله وبركاته. Today إن شاء الله حنتكلم عن ال ABC in thoracic imaging and how to read the chest X-ray. First of all, I have no conflict regarding this talk. Our objective today, inshallah, will speak about the principle of the chest X-ray, how to differentiate between PA, AP view, the principle of some encounter presentation, and how to read the normal and abnormal chest X-ray. Reading chest X-ray طبعا لازم يكون أي طبيب يكون عنده structured method ويكون consistent with that method. كل X-ray لازم يبدأ فيها ويكون consistent with that. The patient X-ray yourself. ما دايما ما تقولش في كتير بعض الأحيان بيجي البيشنت بيقول لك والله عملوا لي أشعة في المستشفى وكانت قالوا لي كويسة ما فيها حاجة. Usually you should look to your patient chest X-ray yourself and to practice for to read the proper way. Interpretation طبعا. Examination of the chest X-ray process requires systematic approach. لازم يكون A, B, C, D because of wrong diagnosis based on only if you concentrate in the only obvious feature in the chest X-ray وبالتالي you can miss a lot of information. And you should need also to satisfaction of search. زي ما احنا هنا for example the chest X-ray, if we concentrate in the lung field, this is erect standing chest X-ray and left lower lobe consolidation, but in systematic approach we will discover this patient is having left lower lobe pneumonia and left proximal humerus fracture. زي ما هو واضح هنا إنه there is a fracture in the humerus. وبالتالي you need to full searching for in any pathological process. Another example بداية يعني to stimulate the brainstorming. What is the abnormality? As we see here, there is obvious absence of the cardiac shadow, ectopia cortex interna. الناس دايما بيكون this is a congenital anomaly in which the cardiac will be in the abdominal cavity. Another example of chest X-ray that need to be read systematically. This patient is a 49-year-old lady presented with recent onset of vomiting, and to look for the evidence of perforation, the chest X-ray was performed. What is the most likely causes of the chest X-ray appearance? Pneumonia, metastatic carcinoma, perforated duodenal ulcer, hamartoma, or pulmonary contusion. As we see here, there is absence of the fourth rib in the right side and a lytic lesion, and most likely caused by metastatic carcinoma. So confirm the details of the your patient data. The image quality also important. Look for the airway and inspiratory or expiratory film, cardiac shadow to look for the diaphragm, and another modality. طبعا we have to ensure that the patient performed for the correct patient. The time and the date is important. To compare also sometimes to compare several chest X-ray. You check for the first chest X-ray, and if there is any obvious time difference between progressive lung pulmonary nodule, الناس اللي عندهم tumor, follow up, non-resolving pneumonia is important also to compare between the previous chest X-ray. Study type also ممكن يكون AP view, PA view. Comparison also the patient's position is very important. Projection very important, that it is PA view or AP view. Usually the patient اللي هو standard احنا we prefer as a pulmonologist a PA view, posterior anterior view is very important for us rather than AP view. The AP view usually done for the patient bed bound, patient in ICU is not mobile, وبالتالي we need to do for them AP view. لكن احنا بنفضل اللي هو PA view. position it is either upright or supine. inspiratory effort دايما الإنسان بيقف أمام الكاسيت تاع chest x-ray and full inspiratory وتتشيك also the penetration chest x-ray الدوز تاعت الراديشن والposition if they're rotated centralized also very important. زي ما حكينا هنا الداتابيز النيم الديت important for comparison the previous exam البوزيشن right and left. بعض المستشفيات يعني ممكن يحط علامة right or left and sometimes you can differentiate between right and left by the aortic knuckle and the left gas bubble. We will also check type of the film and also technical quality. زي ما احنا شايفين هنا this is the PA view and this is the lateral view, this is the AB anterior posterior view and this is the left or the right lateral decubitus. The APC mnemonic is useful when trying to ensure that the examination the chest X-ray is systematic. A denoting for airway, LB for bone, C cardiac, D diaphragm, E and F equal both lung feed, G gastric bubble, H hilum and the mediastinum. I also have to add the T which is standard for technical error. Chest X-ray checklist ABC وبالتالي very important أي طبيب لازم يكون عنده mapping in his brain how to read or how to approach and to read the chest X-ray properly. Checklist we have also to after the check the patient data position, technical quality and normal anatomy. Initial survey, review the skeletal structure of the shoulder girdle, chest wall, ribs, bone, review the mediastinum, trachea position, shifted or pulled, margin تاعت الهارت, superior vena cava, ascending aorta, and the right atrium, left subclavian artery, lines, hilum also. Very important also to check for the lines or mediastinal lines and strips. Posterior junctional line هذا الأصفر, posterior junctional line, right and left paratracheal strips, anterior junctional line and azygoesophageal recess, and also right and left paraspinal strips, and this is as we see here the aortopulmonary window, and this is the para-aortic line, also obvious because widening of this line can give us an idea if the bronchogenic cancer or mediastinal lymph node enlargement, or aneurysmal changes in the vessels. So it's very important for us to know. These are the paratracheal line and aortopulmonary window. Checklist الثانية lungs and pleura. Compare the lung size, symmetry, لأنه في بعض الأحيان asymmetrical can be found in lung atelectasis, vascular pattern, pulmonary parenchyma, pleural surface, fissure. We have two major fissure and one minor in the right. Hemidiaphragm, soft tissue also in the spine and the neck, والبون of the chest. To start with, this is the PA view, posterior anterior view of the patient who is complaining of progressive shortness of breath for the last 2 weeks, associated with fever and cough and pleuritic chest pain initially. Then the pain disappear. As we see here, there is homogeneous opacity occupying the right lower zone, وزي ما احنا شايفين هنا silhouette sign اللي هو right heart border obliterated, right diaphragm also obliterated, consolidation possible, pleural effusion also possible, but absence of both silhouette sign denoting there is right-sided pleural effusion. To make it more obvious, we did for the patient right lateral decubitus view, right lateral decubitus, and as we see there is a free flowing fluid. We can check also for the amount of the fluid. If it is from this point more than 1 centimeter, this denoting almost 200 milliliter inside the pleural cavity. احنا زي ما احنا شايفين هنا أكثر من تقريبا 4 سنتي. This is a lateral view. Check for the anatomy, the basic anatomy of the fissure. زي ما احنا عارفين في عنا اللي هو oblique fissure started from the T3 posteriorly and goes down until the anterior rib 6 rib, وبالتالي بيقسم لنا upper lobe anteriorly more anteriorly lower lobe more posteriorly. وفي transverse fissure بيكون على الرايت side from the 4th rib and بتقاطع مع oblique fissure. How to interpret the normal chest X-ray to learn silhouette sign and can also localize the pathology والpathology. زي ما احنا هنا شايفين هذا دايما احنا الاكس راي بنفضلها اللي هي posterior anterior view. positioning the patient لازم يكون تقريبا patient facing the cassette and the chest X-ray tube almost 6 feet away, يعني 72 inch. distance very important rather than الناس اللي عندهم anterior posterior view. ال AP view في الناس دايما بيكون في العناية المركزة أو الإلدرلي والموبايل patient. وبيكون الفرق بين الكاسيت والشست X-ray tube almost here 40 inches. بالتالي projection here there is a difference between the PA view, the one in the left, and AP view. والفرق بينهم بيكون دايما في projection دايما بيكون العيان برضو مش ماخد full inspiratory film, وبالتالي there is a cardiomegaly as we see in the left side with prominent mediastinum. Also another example, the PA film in the left compared with the AP view in the from a supine film in the right. as we see here also, not full inspiratory. There is haziness in both lower zone comparing to the PA view. So the superior mediastinum appear in the AP view, widen, will heart appear enlarged, cardiothoracic ratio enlarged because of this is the supine view. وbilateral interstitial infiltrate also due the under inflation وبالتالي البيشنت مش ماخد full inspiratory film. Same patient, repeated chest X-ray and the next day. This is the posterior anterior view projection at this time, which is completely normal. Another example to differentiate between AP view and PA view. Lateral chest X-ray, lateral positioning obtained on the left or on the right against the cassette. Lateral chest X-ray it's useful to check if there is دايما في الناس اللي عندهم foreign body inhalation الhairpin inhalation to check it is either the position and for the foreign body. Sometimes patient with hemoptysis the projection particularly good behind the heart. بعض الأحيان في الليجن الناس اللي عندهم lung cancer or hidden area in the hilum, so it will give us also localize the pathology either it is anterior mediastinum or middle or posterior mediastinum. وهنا برضو this is the topograph of lateral chest X-ray with this is the left costophrenic angle, this is the right costophrenic angle, posterior angle. طبعا obliteration of this angle with the fluid denoting there is pleural effusion almost 75 milliliter. Left retrocardiac opacity, the patient in the normal PA view, as we see we noticed here there is left retrocardiac opacity. When we did the lateral chest X-ray, the mass, soft tissue mass was obvious. Lateral decubitus chest X-ray is very important. It gives us two idea, two information about the pleural effusion. First of all, the fluid is free flowing pleural effusion, and the second we can also measure the amount of a fluid if it is more than 1 centimeter from the lateral rib cage until the fluid, if it is more than 1 centimeter denoting almost 200 milliliter of a fluid, and you can easily take a diagnostic tab ultrasound guided, and also give us it is not loculated or complicated empyema. الانسبيراتوري فيلم دايما اللي هو البي اي فيو بيكون في الستاندنج عشان البيشنت بياخد فول انسبيريشن بعدين بياخد الchest X-ray، وبالتالي الفول انسبيريشن the diaphragm should be found about the level of 8 to 10th posterior rib and 5th to 6th anterior rib and good inspiration. This is inspiratory versus expiratory. وهنا زي ما احنا شايفين this is the clavicle، وهنا اللي هو patient they have this is the posterior rib 1 2 3 and this is the anterior rib. So adequacy of inspiration when you can see 10 dorsal rib and 5th to 7th rib cross the diaphragm at the midclavicular line. طبعا زي ما احنا شايفين هنا anterior ribs السادس crossing the cupula of the diaphragm. السادس crossing the cupula of the diaphragm. This means that this is a full inspiratory film. طبعا differentiate inspiratory film هنا very normal, and expiratory film also show there is a decrease in the lung size and haziness in the left side. Patient in the ICU عمره 70 سنة shadowing in the both bases suggests infection. لما تشوف انت يعني في both haziness in both lower zone, but it is because of the poor inspiration, crowding of the vessels in the lung base result from inadequate inspiration. Also in this is a same patient after expiratory film. Here there is the right lower zone haziness after taking full inspiratory film. Also showed there is a disappearance of the right side haziness. البنتريشن also الدوز بتاعت الراديation is very important. Usually the thoracic spine disc is space barely visible through the heart. يعني retrocardiac we should not see the intervertebral disc. Retrocardiac. If we were able to see the intervertebral disc, this is over penetration. The dose is very large, and if it is we cannot see even the intervertebral disc above the cardiac shadow, this is under penetration. It's very important for us to give us an idea about the cases of pneumothorax. If there is pneumothorax, we will not be able to detect the abnormality early. As we see here, retrocardiac shadow, we were not able to see the intervertebral disc. لكن في الأوفر penetration plaque jet appearance والأندر penetration we were not able to check for the any abnormality or the pulmonary vascular structure. This is also lateral chest X-ray. This is under penetration and this is high, and we will not be able to detect even the pneumothorax. زي ما احنا شايفين هنا الvisceral line left side left upper apical pneumothorax. طبعا standing for supine can give us a false impression due to the magnified heart اللي هو ممكن يعمل لنا الكارديوميجالي. وفي الناس اللي عندهم PVU anterior but false negative cardiomegaly. The rotation, طبعا the rotation can be measured between the medial border of the clavicle and the spinous process, and it should be in both sides equal distance from the spinous process of the thoracic vertebral body. Rotation, if the patient is rotated, not centralized, sometimes give mistaking large mediastinum or widening mediastinum, who can be also misdiagnosed as aortic aneurysm. بالتالي this is centralized, the spinous process and the medial and the end of the clavicle should be the same distance between each side. This is a patient rotated film. As we see here, the medial end of the clavicle here on the left side, medial end of the clavicle on the right side, and there is mistaking from tension pneumothorax, or either it is large aortic aneurysm, while it is only a skin fold. An artifact, sometimes medical surgical artifact, instrument, NG tube, chest tube, sometimes patient artifact, hair, sometimes also radiological artifact, the rotation with penetration with inspiration. زي ما احنا هنا شايفين what are your finding in this chest X-ray. زي ما احنا شايفين هنا right upper loop upper zone haziness، لكن after checking the patient, we found that it is just only follow-up radiograph repeated, and just was only the hair tied up. It was completely away, so the hair braid was there. وهنا احنا شايفين برضو this is can be also hair artifact. Anatomy, general anatomy of the lateral view: right diaphragm, left diaphragm, spine, scapula, axillary fold, and sternum, also aortic arch والmain bronchus والcostophrenic angle والcardiophrenic angle. طبعا we have زي ما حكينا اللي هو oblique fissure. This is left side and this is right, where transverse fissure also there. Very important for distribution of we have 3 loops in the right side and 2 loops in the left side. We have 10 segment in the right side, we have 8 segment in the left side. We need to check also for the airway, check for the trachea. If there is a tumor in the trachea, also very important. The trachea is centralized. Very important for us to know them, to check the mediastinum. To check the mediastinum by checking the trachea. If it is pulled in the case of fibrosis, or it is pushed in case of large pleural effusion or large tumor. A trachea, as we see here, left main bronchus divided into right main bronchus, a right main bronchus more horizontal on the right side, and more vertical and wider, while the left side is horizontal and narrower. So any foreign body inhalation, it goes directly to the right side. So very important for us to check. There is a checklist for the trachea, position, shape, if there is narrowing, sometimes a steeple sign, which is upper zone narrowing of the trachea. Here the trachea is centralized. Here also we found there is a filling defect in the trachea, or tracheal tumor, which is very obvious by the CT. Hilar structure دايما بيجي في الأسئلة MCQ. Usually the left hilum is often higher than the right, while the right diaphragm is higher than the left. Very important information. Equalization in the hila, denoting there is either collapse or pulling by mass. بالتالي left pulmonary artery وهنا right pulmonary artery. الhilum in the left is higher than the right, with diaphragm in the right is higher than the left. Very obvious here. The pulmonary artery, the main pulmonary artery divided into the left pulmonary artery, right pulmonary artery. Here the right ventricle. A lung zone. طبعا it's better to divide the lung into 3 zones. An upper zone from the second rib, and up, it is upper zone from the second to the 4th rib. This is the mid zone from the 4th rib to the 6th rib. Anteriorly, this is the lower zone. Lung loops and fissure. طبعا we have also right upper loop and right middle loop, and this is right middle loop in the lateral chest X-ray, and the right lower loop also found in the right lower zone. Any involvement or consolidation, it is also for localization of the pathological lesion. Here, this is the left major fissure. Divided the left upper lobe from the left lower lobe. There is accessory fissure. Sometimes we found azygos fissure. When the azygos vein usually runs horizontally along the right side. This is the azygos vein. بيعطينا this is accessory fissure. Costophrenic angle زي ما احنا شايفين هنا obliteration of the this is costophrenic angle where this is costophrenic creases. Obliteration of the costophrenic angle denoting there is 175 milliliter of fluid in case of a pleural effusion. And cardiophrenic angle also sometimes we have to look at if there is any obliteration and cardiophrenic angle we think about pericardial fat pad and mediastinal lipomatosis. Diaphragm زي ما حكينا right side it's higher than the left. The outline of the diaphragm on both sides should be clear and smooth. Gastric air bubble usually can give us an idea about the left side of the chest X-ray إذا ما كانوا حاطين right or left. Aortic knuckle also can give us an idea. It's usually in the left side. Patient with carcinoma of the ovary underlying chemotherapy, 49-year-old female. Can we see here also there is the gastric bubble here, but there is also a wide distance from between it and the diaphragm. Subpulmonic effusion in the left dome of the diaphragm is higher than the right, which increases the distance of the diaphragmatic outline of to the fundal air bubble of the stomach, suggestive of subpulmonic pleural effusion. The cardiac thoracic ratio should be more than 50 is abnormal. Cardiothoracic ratio more than 50% is abnormal. This is denoting cardiomegaly and heart failure. Was very important ominous sign to differentiate في حالات ال ARDS cardiogenic from non-cardiogenic pulmonary edema. An important also clue sign also to differentiate one of the important questions during exam. I can show you a chest X-ray till you show me the border of the heart. The border of the heart, the right atrium, anteriorly the right ventricle, and the left side left ventricle, and this is aortic pulmonary. This is the pulmonary artery, and this is the aorta and aortopulmonary window, and superior vena cava in the right side. Also, the edges of the heart and the mediastinum should be clear. Obliteration of the right silhouette sign of the heart border denoting right middle lobe consolidation, and absence of the right diaphragm denoting right lower lobe consolidation. Middle lobe atelectasis sometimes difficult to differentiate or to detect, لكن في lateral chest X-ray very nice right middle lobe consolidation. Here also the important answer for the questions is show me the border of the heart, right atrium, this is the right main bronchus, and this is the superior vena cava, this is the right ventricle, this is the left ventricle, left atrium, and the pulmonary trunk, and this is the aortic arch or aortic knuckle. Normal aortic knuckle, give us an idea. This is the left side of the chest X-ray. Fullness of the aortopulmonary window can give us an idea about bronchogenic cancer, mediastinal lymph node enlargement, or aortic aneurysmal. This is a case of aortic arch aneurysm. As we see here, there is obliteration of the aortopulmonary window. طبعا الميدياستينال structure في anterior mediastinal وفي middle mediastinum وفي posterior mediastinum. Common questions of the anterior causes of anterior mediastinal mass or soft tissue mass اللي هما 5T: thymus, thyroid, TB, terrible lymphoma, teratoma. Very important. differential diagnosis زي ما حكينا في الانتيريور mediastinal والميدل mediastinum اللي هم الهارت والبريكارديوم والاسcending and transverse aorta. superior vena cava, pulmonary vessels, trachea, main bronchus, والposterior mediastinum also in case of lymph node, thoracic duct, azygos or esophagus. The posterior mediastinum usually neurogenic tumor, esophageal tumor, neuroendocrine cyst, or descending aortic aneurysm. Then we look for the soft tissue and the bone. Very important to check for the bone, for the lytic lesion of the bone, for the fracture of the tibia, fracture of the humerus, clavicle, centralized. This is the posterior rib, this is the anterior rib. Distal clavicular fracture. This film shows a distal clavicular fracture when the monitor cord is removed. Also, rib fracture can be sometimes be extremely subtle ومش واضحة. Here in the patient with right side chest pain after an all-night party, the patient doesn't recognize any history of a trauma or injury, but by doing the chest X-ray, there is a several posterior rib fracture, flail chest. Also, we have to look for the hidden area in the chest radiograph. Diamond behind the both the clavicle and the hilum, also in the behind the diaphragm. Also very important to check there. A hidden area, apical zone, hilar zone, or retrocardiac zone. This is the patient with chronic cough and heavy smoker. No obvious lesion in the PA view. لكن by doing the chest CT scan, there is right lower lobe soft tissue lesion which is behind the cupula of the diaphragm, which was not obviously seen in the PA view, which considered the hidden area, which is very important to check for any lesion there. Again, the sequence, data, routine technique, airway, bone, cardiac size, costophrenic angle diaphragm, enlarged lymph node, soft tissue. This is right middle loop consolidation. As can we see here, also the slow sign of the right heart border also obliterated. وبالتالي this is right middle loop consolidation. Air bronchogram, tubular outline of an airway made visible, filling of the structure surrounding the alveoli. Air bronchogram is assuring signs actually, and give us assuring that this is not a soft tissue mass, it's a consolidation or pneumonia. Here, as we see, the air bronchogram sign. Here, a bronchogram sign, what's very prominent in the CT scan. Tubing in the air bronchogram, which is assuring sign this is a pneumonic process or consolidation rather than soft tissue mass. Atelectasis, a linear increase in density, volume loss. So the volume loss, asymmetry of both sides, vascular crowding, diaphragmatic pulling up, also associated with atelectasis. This is the right upper loop collapse, which is called golden sign or inverted S-shaped sign. This is left upper loop collapse. Pulmonary edema, we have to differentiate between cardiogenic and non-cardiogenic. Cephalization of the pulmonary vessels. في pulmonary edema usually there is cephalization of the pulmonary vessels, prominent congestions of the pulmonary vessels in the upper zone, Kerley B line, septal line, peribronchial coughing, pattern of opacification or pulmonary edema, and increase in the cardiac size, cardiomegaly. بعض الأحيان ممكن نلاقي pacemaker or CRTD. This is a patient with pulmonary edema, cardiomegaly, bat-wing appearance, congestion, and cephalization of the pulmonary vessels, and Kerley B line. It is not obvious here. This is non-cardiogenic pulmonary edema, normal size of the heart, bilateral wet lung, whiteout, in both lung field, denoting this is non-cardiogenic or pulmonary edema or RDS. This is a very nice Kerley B line or septal line in case of patient with cardiogenic pulmonary edema. زي ما احنا هنا شايفين البيس ميكر واللوب بتاع البيس ميكر. النيمونيا, airspace disease with consolidation, either it is lobar or lobular pneumonia or interstitial. طبعا اللوبر نيمونيا بيكون البروبلم primary location of infection in alveoli, البرونكونيمونيا في البرونكاي, والانترستيشال نيمونيا في الانترستيشيوم. Usually in the chest X-ray, dense consolidation with air bronchogram in lobar pneumonia. في البرونكونيمونيا patchy opacity. في الانترستيشال pneumonia diffuse hazy opacity with septal thickening. And الميكروبيولوجي most likely streptococcal pneumonia, klebsiella pneumonia, legionella في اللوبر pneumonia, but in bronchopneumonia mycoplasma, chlamydia, pseudomonal, where usually the viruses and pneumocystis jirovecii, mycoplasma can cause also interstitial pneumonia. This is a case of lobar pneumonia. Right middle loop consolidation. This is right upper loop consolidation with obvious air bronchogram sign. Dense consolidation in lobar pneumonia with air bronchogram. The process may asymmetric with some loop completely filled while adjacent loop are spared. Bronchopneumonia, bilateral patchy infiltrate. In case of mycoplasma, as we see here, patchy infiltrate. This is a case of cystic fibrosis with bronchopneumonia, diffuse patchy pattern infiltrate. Interstitial pneumonia, usually affecting the interstitium, ground glass appearance, pneumocystis jirovecii pneumonia case with bilateral ground glass appearance in the CT scan. it's very important for us to localize the site of pneumonia, either it is right middle lobe, right lower lobe, or and very important for us silhouette sign for differentiation. Also here, as we see, this is a patient, one of our patients. He was having history of bronchial asthma and admitted with chest pain, dyspnea, repeated cough. As we see here, there is multiple surgical emphysema, subcutaneous emphysema, also subcutaneous emphysema in the neck, and continuous diaphragmatic sign denoting there is an air retrocardiac. There is double contour here, a pneumopericardium, and this is a case of pneumomediastinum. Ring around the artery sign in case of pneumomediastinum, when the air around the pulmonary artery in the lateral view, and a double bronchial wall sign. This is a case of cystic fibrosis, and this is Heimlich valve for the long-standing antibiotic. And as we see here, there is a ring shadow and a tram-like appearance in case of cystic fibrosis. This is right upper lobe collapse. As we see, there is asymmetry between both sides. In the right side and the left side, there is a smaller size in the right, and crowding of the ribs. There is decrease in the distance between the ribs in comparison to the comparison to the left. Pulling of the diaphragm, and this is inverted S-shaped patient with right hilar mass causing obstruction of the right upper lobe bronchus, where this is the transverse fissure pulled up, causing inverted S-shaped sign. This is the right lower lobe collapse, and also this is right lower lobe collapse. This is Loftschild sign, a left upper lobe collapse, and there is haziness on the left side of the chest X-ray, or زي الستارة عاملة in the veil sign in the left side. Any patient presented with collapse, this is alarming sign. Either there is endobronchial lesion, endobronchial mass, endobronchial foreign body, or atelectasis or tenacious secretion cause collapse. So it's very important to evaluate this patient properly by bronchoscopy and CT scan. This is also left lower lobe collapse. This is one of our patient also admitted because of acute onset of left side pleuritic chest pain, sudden onset associated with hemoptysis, and this is a triangular shape, pleural based Hampton hump sign. The patient was having elevated kidney function, so we were unable to do for him CT angio with contrast because of impaired kidney function. The normal we did CT without contrast, and it showed that there is a bubbly consolidation. As we see here, bubbly consolidation, which is very confirming sign for patient with pulmonary embolism. Thank you.